following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
What are you going into? Or what are you applying to?
Oh, I'm sorry. Oh, psych. I applied to psych and peds both. Yeah.
Cool.
Yeah. So it's gonna be a real surprise what happens on match day.
Open up that envelope.
Oh man, yeah. I was just talking to Dave about we should make an episode all about residency applications because there's just demystify it a little bit because there's just not a lot of great advice out there. There are some like websites that are really helpful, but for the most part, it's
doctor at work.
I don't know, very nebulous.
We're working on right now. There's more resources coming from M4s for y'all's class and the M3s.
Oh, awesome.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
By students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast, the show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, her content is always so creative and inspiring. It's MD PhD student Aline Sanduk.
Hi, everybody.
The way he engages with his audience is amazing. It's M1 Trent Gilbert.
Hi, everyone.
His passion for his work is inspiring. It's M4 Nathan Spitz.
What's crack-a-lackin'?
And he has a way of making complex topics accessible. It's M1 Leon's son.
What's up?
Welcome to the show, Trent.
Woo-woo!
What did you do before you were a medical student?
It's a good question. I worked for a year in tech, actually. I was a software engineer.
Oh.
Yeah, it's pretty random.
What?
I don't really do anything with it anymore.
Why did you switch gears?
I spent a summer interning, and I asked myself, what would I be doing in 20 years, 10 years? And I came to the conclusion, like, I would probably become a manager of some sort. Then I saw what my manager was doing, and I was like, well, I probably would prefer that, but also, like, I'd be limited to this, like, 45-minute commute across the Bay Area every day, each way, and, like, constantly nagging people about what they were doing and for what, and, like, worked for a company that made TurboTax, and, like, just not what I want to leave.
Yeah, and now you'll be nagging people to watch their weight and
fill out their evaluations,
and
get their RV, get their clinics signed or their notes signed and submitted.
Yeah. People face trade-offs.
Yeah, that's all. Well, I am happy to see you on the show. Thank you for joining the fun.
You also answered like 5 residency interview questions in the span of like 2 minutes. Like, what were you doing before medicine? Where do you see yourself in 5 to 10 years?
How do you overcome adversity? Apply to med school. That's cool. Welcome.
So much of what we do in life, and especially in medicine, requires trust in order to do it well. Ideally, we trust our families, our friends, our bosses, our political institutions, our spiritual leaders, and of course, our doctors. I feel like every single one of those things that I mentioned just now could be a laugh line.
I cringed when you said institutions.
Yeah, I mean,
and coincidentally, all of those categories include some of the best predators and serial killers of all time. Just to be clear, it can go both ways.
I, for one, have deep trust of George Santos. Oh, I got political. So sorry.
Who is this guy?
Nobody loves George Santos.
I think this is a bipartisan acknowledgement.
Yes, I think you're right.
He is not a trustworthy person.
So thank you, George Santos, for providing Dave with a political foil that he can actually mention on the podcast without engendering a whole bunch of hate from...
Giving something for
Thank you, George.
Democrats and Republicans to unite.
Yeah.
We'll see how it plays out. Yeah.
Yeah, it'll be interesting.
I mean, who is this guy? He could be anyone.
He could be one of us.
He could be a doctor. Yeah. We don't know.
He will. He probably is a doctor.
Yeah.
Graduated from Baruch, NYU, Carver College of Medicine.
Oh, God.
Anyway, today I thought we would explore the idea of trust. Anyone want to sort of hazard a definition of what trust is?
I think I can give it a try.
Go.
Trust is the belief that an outcome will occur despite you having nothing to do with it.
Interesting.
Yeah, that's my first thought about trust.
Say that again. Trust is
the belief that a desired outcome will occur without my having to do anything with it.
So give us an example of this definition.
Can you make sure this person takes their medicine on time? I have to go. I will trust that person will get it done.
So trusting in your colleagues
yeah.
is, I think, what you're saying.
I think you could extend that to the most global. That's what trust is I believe that you will act in my interests, even though I'm not here to specifically watch you do it.
Fair.
Correct.
Right?
Okay, now I get it. Okay.
Yeah.
Cool.
But what does everyone else think?
The word maybe that was coming to my mind was a surrender, and I think it was kind of like a surrender of a loss of control, and which would then create the belief or expectation that.
So surrendering your control over a situation,
I agree,
in favor of another person's,
with the acknowledgement control. Of, like Aline said, that I, won't have an impact or. You may have an impact, but won't have. I guess this is circular reasoning to say control, but
no, I agree. Yeah. You're surrendering agency.
There we go.
To another entity you have no control over. That's profound. Yeah.
I think it also has to do with the kind of capital that the person or entity you're surrendering or trusting has built up. So in a medical colleague, well, that person has gone through training, and maybe that person and you've seen them do certain work, and that allows them to build a certain level of capital. And you're okay, I can ask them to do an important task and trust that it's going to get done. Whereas somebody George Santos, I don't know George, I don't know anything about him or what his accomplishments actually are. I wouldn't trust him. Yeah, exactly. Yeah, so he hasn't built up any of that capital. There's no reason to trust him.
Hey, he's rocked the drag show in Brazil before.
I trust it. Yeah, I mean,
I would trust him to run a drag show. Yeah,
just having fun in college.
Except he actually did that one, right?
Yeah,
as opposed to everything else that we've heard about.
He has built that social capital.
Good on you, George.
I think in terms of trust, I think it's what you substitute for information you might otherwise have, and predicting a given outcome. I think maybe you aren't able to observe all the steps of the process to ensure that what you hope is going to happen happens, or maybe you are going to observe it, but you're not going to be able to exert any control over it. I think trust is what steps in there and helping you actually believe in something or proceed with a given decision.
So maybe this is the trust that patients have in their physicians, for instance. If they're they typical patient doesn't have all the knowledge that they would need to make determinations about the next step, perhaps, but they trust their physicians to have that knowledge.
That's hopefully, a good one.
Ideally.
Yeah.
The belief that someone with more expertise than you will not use it to exploit you, but will use it to your benefit. Because anyone who knows more than you is in a position to exploit you. That's true.
I feel like the past few years have really tested our definitions of trust. As America becomes more polarized, as during the pandemic, the trust that people had in physicians and science was really it wasn't well demonstrated. I'll say that for whatever reason. The trust in our political institutions, the trust in our bosses and our workplaces to do the right thing. All of this was tested.
Trust in institutions.
Across the board. Families who maybe disagree about politics or even things like, vaccination or things like that. All of this has come into question. I feel like the age of trust in each other might have at least temporarily come to an end for many people.
I feel like the basis for civilization is trust, right? The only way we've been able to move forward as a human race, move out of caves where no one trusted anyone else, but, we're able to come together and work towards a common goal that benefit everyone. The entire foundation for that is trust. I just realized as you were saying this, how incredibly deleterious it is to society that no one trusts anyone anymore. And once you lose trust, it is incredibly hard to get it back.
Yeah.
Like, I don't know of a lot of people that stay together after there's been infidelity. And of course, I haven't done the science on it, but like, according to Reddit, it is very painful. And most people just can't get over, like, nothing short of following their partner around permanently and having permanent access to their phone, they'll never be able to trust them again. Like, it's kind of tragic, but like, what's going to happen to us?
Yeah. I was while we were listening, thinking of like, I was putting a lot of blame in the US on like our individualistic culture and the lack of trust, that we care for ourselves and that we don't trust other people for our care or concern, or that an institution would have our best interest at heart, or that science is true or real. But then I also was like on the flip side thinking of countries like China right now. I guess they had just gotten rid of what was the COVID policy? Zero COVID policy, right? Where people in China had put a huge amount of trust in a more kind of collectivist society into their government, and then also started to revolt against that loss of trust or loss of faith that their government was doing what was best for them. And so I don't know. I initially had thought that it was our individualistic society in the US that had led to like such a huge distrust, but I guess we're seeing that.
Well, I think the two situations are a little bit different, because like with the US, I do think the individual, or the value of individualism in the US kind of is one of the root causes of the situation we're in now, and certain people have kind of exploited that for, political gain. I think in China, I think what it was there was a loss of belief that the government was in touch with the people. So like when the shutdowns initially happened, people were willing to tolerate it until it got to the point where like, my dad's there right now, so I hear a little bit, but once like people couldn't get food or like basic needs met, and then it got to the point where like the fix was worse than the virus itself. All these other countries are opening up, people see this on the news, and then there is this lack of belief that like the Chinese government is actually like in touch with kind of what the people are actually concerned with. And I think that kind of led to a lot of the rebellion and eventual lifting of the policy.
So the trust only extended so far. I mean, trust isn't absolute. You have to continue to sort of demonstrate your, sort of worthiness to be trusted. And, part of that trust comes from the knowledge that the other party understands what you need.
Yeah.
Right?
So if we bring it back to kind of the scope of medicine, like you wouldn't trust your doctor if you figured out your doctor was like, had some other motivation for seeing you, or
for say prescribing.
Yeah, or prescribing
certain medications for you, or
just you got the sense they didn't have your best interests in mind, or that they didn't really understand you. That would be.
Yeah, I mean, this is why we have things like, the policy where we have to disclose our financial relationships. Even I have to fill out this policy. Like nobody's, I have to fill out this form that says I have no financial relationship with, this, that, or the other company.
As annoyed as people get with like rules like that, the fact is like those things exist because they're needed. Because there was a person who had serious, not just one, but probably multiple people who had conflicts of interest, did not disclose them, and were
it used
rolling
to be
in the bank.
Yeah, well, it used to be that, you would, I remember when I was a kid and my father was a physician assistant, he would come home from these conferences with like bags of swag bag. And, it was all trash,
But free is very sexy. Free is extreme. Free triggers something in our brains that is like just lizardian, and we just can't help ourselves when someone says
that
free.
Scarcity mindset.
And you would hope that, I think a lot of people sort of felt like, well, this doesn't have any influence on me, but influence is also subtle.
Yeah, even if it's just priming. I mean, you can like social psychology, just like the primacy or recency effect, like you see something more often. Even if you take a pen, you use that pen, you see that pen every single day as you're writing prescriptions, and you're choosing between two different, SSRIs, and you see one for.
You'll probably go with the one that you were that you were familiar with.
Yeah.
I mean, those clipboards with the drug name on the clip, you're like, your eyes are directly pointed at that every day. It's brilliant branding, actually.
And if like you want any more evidence, just like look into like during that period where like the pharma companies were pushing these things, like they were putting money into like getting in doctors' faces and giving them free stuff. Like they would not do that. Yeah, exactly. They would not do that if it wasn't working.
I guess there's also, I mean, the other component of trust is trusting in ourselves, which is huge for people in medicine. I mean, you are aware of the trust that your patients put in you, and hopefully that makes you consider whether or not you deserve that trust. You know, Aline and Nathan, you guys are approaching the end of your schooling, your formal education, or I guess your undergraduate medical education.
Yeah,
there
buddy.
we go.
Yeah, buddy.
You guys are approaching the end of your undergraduate education in medicine, and people are going to start looking to you as trustworthy physicians. Mm-hmm. And to some extent, your ability to be that trustworthy physician depends upon the trust that you have in yourself. That when push comes to shove, when you have to make a decision, a medical decision for your patient, how do you trust that you're going to make the right decision?
I mean, you're talking about anxiety. I think the way that has been institutionally established to generate that trust is sheer repetition. And this is a pretty common therapeutic technique for people with anxiety is go do a thing where the outcome is so predictable that it will quell your, because what is anxiety, right? It's the fear of an outcome that has a very low probability of happening, right? So how do you combat that? Go do a thing that is extremely predictable and you will predict it correctly every time, But I think that's how we do it in medicine. The repetition isn't just for learning. I think it's to build confidence and to generate, I don't know, that gut feeling. I've been in therapy a long time and I feel good, but it's a good place to kind of explore yourself, explore your thinking. And it was in therapy that I realized how much I have been conditioned to disregard my own judgment and my own impressions and my own gut feeling. How many people actively, taught me and manipulated me into ignoring my instincts and not just on an individual level. And I think that this is I think everyone is subjected to this, but I felt it even more so as a woman. I think women are told that they're being dramatic or crazy or unreasonable. And I've invested a lot of time and energy in building trust in my own judgment and believing what's in front of you, especially when it comes to people, when what someone says and what they do are not in agreement, trust what they do, not what they say. It's so much easier to lie than to fake behavior. Yeah. But you cannot fake what your true instincts are, what your actions are.
I like the concept of practice and repetition. And maybe my trust is, I don't remember what the term is called, but when you learn more, it's kind of like the education slope. The more you learn, the more you know that you don't know. And knowing as we move into this next step, or that we'll have even more control in the theme of trust, or that the buck can stop with us, or that we will be the ones prescribing medications, that my acknowledgement of my limitations or acknowledgement of that fear or anxiety will promote me to double check, will promote me to look on up to date, to make sure I have the dosages correct, will make sure, to help kind of quell some of those anxieties or uncertainties that my actions aren't going to harm somebody.
Shortcoats, we love to hear from you, no matter what it's about. So call us at 347-SHORT-CT with questions, shower thoughts, complaints about your situation, whatever you like. We'll talk about it on the show. I recall from 20 plus years ago when I was training bus drivers, I used to tell people that it's easy not to make a mistake in the early phases of you driving on your own, right? When people, about 6 months in, there will be a time when, if you're lucky, there will be a time when all of a sudden you're like, holy shit, I've been driving for an hour now and I don't remember anything of what happened. And because your brain goes into some sort of automatic, it's not a very exciting job, right? I think the message there is, is against overconfidence.
Correct.
Right? You got to be careful that, your trust doesn't extend so far, that your trust in yourself doesn't extend so far that you're going to miss stuff.
What do you guys think about that? You're kind of, right at the beginning. Do you think that's going to change? Do you have a lot of self-trust, a lot of self-doubt? Also, feel free to be like, I don't want to answer that question.
Well, I think trust is interesting, like in an individual context, in that I think it's both earned, like you have to earn trust, because overconfidence is obviously not good and leads to a lot of terrible things in the world. But it's also necessary, right? Because at a certain point, you have to have a baseline level of trust in order to do any said activity.
Function, yeah.
Like to vote, for example, like you probably have to trust that somebody's going to count your vote, or else like, that's going to change your calculus around it, right? And like at the same time, when you consider, building that trust in yourself, like I remember when I started driving, like I would always like park in like the corner of the parking lot, because I was always concerned that I would hit some other cars, and I probably did that for like a week, and then like did anything change in turn? I mean, sure, I parked between lines a bunch, but at a certain point I had to just decide, well, now I need to start trying to park by other cars, right?
The most responsible 15 to 16-year-old I've ever heard of. Good for you. Good for you, Trent.
I was just, complicated thing, but like, right, like, I think it says something, right? Most 16-year-olds are just going to immediately start parking by other people, and, like that, was that really earned? No, but it was also probably necessary, because like, how else are they ever going to start driving? Yeah. Like, think about how much trust is just involved in that process. Society has to trust to give 16-year-olds a driving license. Other states don't do that.
Driving is one of those places where we give a lot of trust to other people that we've never met before, that we have no reason to trust. Like, why would I believe that other people are going to stop for a red light that I may not be able to see? Like, think of how much trust we place in people to follow the rules of the road.
I feel like this every day when there's like I'll be like turning out, and there's a car coming in, and they have their signal, so they're gonna like turn at my exit, and then it's like, do I go, or do I trust that their signal is on for good reason, or are they gonna slow down?
Did they forget it?
Maybe they forgot it earlier, and I'm just gonna get T-boned like an idiot. So,
and speaking of, it's interesting too to. I think a lot of it's boiling down to repetitions, right? Like we have a lot more trust that we're going to be okay driving to the grocery store in our car,
which is demonstrably bullshit, right?
Versus people who have like deathly fears of getting on airplanes.
Yeah.
And like the odds that you die in a car crash are higher than an airplane crash. But again, I think it comes down to a loss of control and a lack of repetitions, like we talked about.
Yeah.
Maybe these are the tenets of trust.
But it's interesting, right? Because like you can be an excellent driver and still get in accidents, and like people will still blame you, right? I mean, I think a lot of that's outside of your control,
Well, I feel like the way we've taken control, like thinking about everyday life, you're right. Like the amount of trust I put into my bus driver to not crash, into the residents that are teaching me to teach me what I need to know. Like the only way we've been able to function as efficiently as a society as we do, because it is to trust everything, because the alternative is to do everything yourself. I'm not going to build a car myself. That's ridiculous. But that would be, so like we kind of have to trust to be able to engage meaningfully in society. The thing we haven't talked about yet is like trust but verify. So like we had like, having rules that force people to disclose their conflicts of interest, that's what empowers us to trust, right? Like airplanes are incredibly safe because there are like very strict, guidelines, and also like profound penalties for supposedly for breaking the rule, continuing to fly a plane. Yeah, supposedly. Yeah. But like a lot is asked of you, but we are, and I think this is what has been hard about this modern era, is that it feels like the demands we are putting on others to prove that they are trustworthy are eroding. And not just eroding, but actively being degraded by people who would benefit from you just blindly trusting them. I think that's why people are so tense now.
Well, when you say trust but verify, that made me think of, the fact that, as an you are working under the supervision of other physicians who are verifying, hopefully, that you are, that you have the knowledge that you need, that you have the support that you need to make the right decisions. One of the things that occurred to me recently, I can't remember what made me think of this, is so who's verifying you're attending? I was thinking recently of a story I read in the news about an anesthesiologist who, there was an accident while he was giving an epidural to a pregnant woman, and he did it wrong. He did it wrong, and she died. Her baby was saved, but she died, and it turns out that he's been doing it wrong for a while. When they went back and looked at his case, he's been doing it wrong for a while. And a lot of other people were hurt by this anesthesiologist. And I'm like, who, when you get to a certain point, who watches the watchers, right?
Yeah. In terms of like prescribing medications, for better, it's for worse, but the for-profit insurance companies definitely are watching or verifying what people are prescribing. And to a fault, I think a lot of people aren't able to access medications or therapies that they need because these third parties, i.e., United Healthcare, Blue Cross Blue Shield, etc., have money in the game to watch, to verify what people are prescribing, and then to put it against guidelines, against research, against studies that show, hey, if you haven't tried X, we aren't going to, they have verified. They'll look in charts. They'll look up prior treatments. Is it always for patients' best interest? No, but at least on like a prescribing front, there are, I would say, for most people who are like verifying or authorizing what prescriptions are being dispensed to people. I know there are also like note audits, at least like at I'm sure at every institution, people's notes will get audited if they're too sparse, if there's billing codes or errors. There are M&M or morbidity and mortality. Again, a lot of these are like speaking from their perspective at an academic institution, but there are also morbidity and mortality conferences where attendings and providers from across the specialty and sometimes interdisciplinary will come in and talk about what went wrong. What you're talking about there is physicians helping each other be accountable. Correct. Yep. So I think there's
to restore trust.
Yeah.
Sorry.
I was just going to say, yeah, it seems like there's at least multiple levels of fidelity testing, so to speak. It's never going to be 100%, especially in procedural specialties or in procedures in general. I don't think very many people will like open up a chest cavity to make sure you did every stitch correctly. Or I remember there was one guy who was like initialing his patient's livers or something like that. Yeah, right. Like people aren't going to open up somebody's chest to verify that. People aren't doing that, but.
Can I just as a deflection, a tangent to that, like who was he trying to impress? Like who was gonna see that?
Like a pathologist, maybe?
Right. Like was he planning to murder them later and be like, I've really been trying to impress this medical examiner, actually. What was he thinking?
He was an artist. He had to put his name on
it was
his
for
work.
himself. I think it was pretty clear. It's just like, I feel like it's just like a power thing. Like you're in there and you're like, well, like nobody's gonna know if I like maybe do this. But yeah, total psycho behavior. Yeah, but I'll know. Exactly.
And speaking of like verifying information, it's so wild to think of the trust patients have in us and our ability to just like totally F it up. And I'm thinking of, even as a medical student, you're in clinic and patients ask, statistical questions or research questions about medication. So if you talk about a side effect, like, well, what's the percentage of people who get this? And I don't know the exact percentages. I couldn't name the study. I have a.
What do you say?
I have a gestalt. Yeah. It depends on my familiarity with the subject matter. So, for example, I'm thinking of like sexual side effects from SSRIs. I can like pretty confidently say, at least from studies where people self-report data, roughly 40 to 50%. But like that, I highly doubt most patients are going to go home and like PubMed or UpToDate those statistics, those like pieces of information that I provided, that they maybe blindly or not blindly, but whether they integrated that as facts or as knowledge, I'm not sure. But it's kind of wild. And we saw this exploited with research on vaccines and, physicians and other providers kind of exploiting that trust and skirting it away from.
That's why I kind of have been thinking about what you were saying about kind of insurance companies and these groups that will kind of look over doctors' notes and what they do. And it's like, you're totally correct where like they're in it for the money, but like is the University of Iowa like well suited to just be like detailing over the work of attendings and making sure it's all good and everything's done correctly? And the answer is not really, because, or, you know, they just don't have the resources to commit. But then these like insurers who, yeah, they have skin in the game, they have money in the game. Like I sometimes wonder, well, they have this like mechanism in place to kind of look over what people are doing, and they have an incentive to make sure it's being done according to like clinical practice guidelines. I wonder if there's some kind of middle ground where they can help catch some of these mistakes before they happen. Like maybe if they had seen like, you know, the anesthesiologist that had been performing procedures incorrectly for a while, what if there was some mechanism in place where they could be like, hey, like this one guy or like this hospital's outcomes for like epidurals are like worse for some reason. And then they can locate it to a department and then like flag that. That could be, that's probably an unpopular idea, because what it means is these insurance companies are getting way more involved in like.
It doesn't have to be insurance companies, you know, like I think the problem with insurance companies is that their motivation isn't necessarily better patient outcomes. Their motivation is to spend less money and accumulate more profit, right? So
right, but there's like an overlap between the two, right? Because if you keep your patients healthy, the insurers are going to spend less money because you're not, you know.
I don't trust
the U.S. government does this. I don't remember the exact terminology. You'll learn it in like the MAS 3 small groups, but Medicaid, Medicare, like the U.S. insurance company or whatever, federally funded, state funded Medicaid too, will like designate hospitals or treatment centers based on like outcomes and like quality according to those facilities. And I can't give you even more. I'm like, I can remember the session. I can't give you more information beyond that. But if there are like poor performers or if there's poor health outcomes, et cetera, they'll like lower the tier or ranking and like not necessarily like cover procedures at that institution as well. And kind of like institutionally, I'm thinking of like the OB department, for example, like tightly monitors the amount of C-sections versus vaginal deliveries that they do. And they like have individual provider level. They have like nurse midwife versus
they basically look at your statistics and try to figure out if you are providing the right outcomes.
And so it's not necessarily insurance companies, but you know the state also will monitor opioid prescriptions and controlled substances. And so I think surgeries are a little trickier, but they do track, you know, readmission rates, they track post-op infection rates, they track death rates associated. So I think there's not a lot of like in the moment monitoring.
That is where like healthcare is. Maybe if you look at kind of, so CMS, what you're talking about, so that's Center for Medicare and Medicaid Services. So a lot of their demonstration projects that they do now are related to like outcomes. And so they'll like set metrics, and then you can do payments that are based off of like your outcomes. That's kind of a simplification. So that I feel like that is a good direction for like healthcare to move in, kind of away from volume-driven models, towards outcome-driven models. And that could be like another form of accountability and like trust building, that we know that there's a financial incentive, not for, you know, doctors just in hospitals to like generate volume and do procedures, but rather to make sure their patients are healthy. That could be another form of kind of accountability that's not tied to an insurer.
You know, I think I hear what you're saying. What you're trying to say is, just because their motivation is not altruistic, it doesn't mean that the actions they're carrying out don't have like good, like there's room for both. You know, profit seeking and altruism to intersect.
That's the only way altruism can work in America, is if like aligned incentives.
You're absolutely. I kind of agree. I do agree that like trusting an institution to police its. Asking anyone to police their own behavior is a very risky thing. And
because there's always going to be somebody who, I mean, you know, no matter how much you try to hire people who are going to do the right thing, and people who have a high sense of, or, you know, who value honesty and integrity highly, you know, people are going to slip through, and there's always going to be that one.
You know, even unintentionally, the fact is that like people are always going to side with the known over the, like, you know, I'm thinking of a specific institution or like a specific process, but the fact is that like asking people to, you know, like we looked into ourselves and we've concluded we did nothing wrong is 90% of the outcomes of these, you know, supposed, you know, internal reviews and things like that. I firmly believe that people should be, or like institutions should be evaluated by an outside force, whether it's, you know, I agree. I would prefer a group of people that were elected and that, are beholden to us as a public versus maybe a profit, making organization. But it doesn't mean that existing mechanisms can't be harnessed to the benefit of patients. And so ideally more than one set of eyes, really.
Yeah.
Slay.
Yes. I'm thinking of like police institution, all these like internal reviews and anyway, I digress.
Just to like follow up on that point, the amount, like the extent to which like TV shows lead us to believe that cops hate like IR and like internal review, I think that's propaganda. I don't think that they hate them as much as like they actually do in real life. But I don't know. I don't know a lot of cops. But
it's a lot. It's probably more work for them because it's internal review, so it'd be more work for them. But yeah, I'm sure they would love that more than, like you said, an elected, like not a school board, but some type of like public safety council.
Shortcoats, if you're enjoying our conversation today, I'd be grateful if you'd let people know by posting a story on Instagram or Facebook or tweeting about us. And don't forget to tag us in your post.
Thank you.
Have you ever felt a lack of trust from a patient?
Oh, 100%. I don't know what your experience on psychiatry has been, Aline, but especially on inpatient psychiatry rotations, this is something that I still like grapple with. And there's debates in the field on whether we should allow involuntary psychiatric commitments or not. I'm thinking of people who are actively, experiencing psychosis right now. And there's one patient that comes to mind that I was caring for who had been admitted several times before, always involuntary commitment, never believed that he had a mental illness or had schizophrenia, totally disagreed with the diagnosis and just had such a distrust for the system. On an air quote, it's always subjective, but was struggling to care for himself and was brought in by police for harassing other people, trying to like minimize identifiable information. Regardless, this person, did not trust us as healthcare providers that we had his best interest in heart. He didn't trust that he had a diagnosis of schizophrenia. He didn't trust the treatments that we had. And so we had to, the residents on the team had to call into the courts and like legally strip this person of their rights and freedoms to hold them on our unit. He continued to not trust our diagnosis or treatments offered. And then like the result of that was that we had to wait for the court order to come in to like give intravenous medications against his desired or expressed will. I would say when he was discharged, there were breaks, or you could see kind of like slivers of increased trust, or at least he expressed to us that he would, we had put in, there's kind of like legal ways to pull people back into treatment if they don't show up, but had expressed that he would come in. So I think it like improved, but every single like moment of that person's hospitalization, just like a lack of trust in us as people, that we were telling the truth, a lack of trust in the system. And that's a tale, I guess, as old as time in psychiatry. But
how do you react to, what's the best way to react to a patient who doesn't trust you?
I think in a common this is across specialties, is to ask questions, to be curious, to ask, why, what, is there one, I guess you can ask why or how people would come to that conclusion. So, I'm hearing that you don't believe this. Like, can you help me understand how you are thinking about this? Can you help me understand, or can you please explain, what we can do to better understand? So I think it comes from both perspectives. For one, for us to ask and try to understand more, and then to also look back on ourselves and question ourselves and see what we can be doing better, how we can better connect with people, even if they do distrust us, to try and build some of that gap. Again, to, we were just talking about, having aligned priorities, I think, are some of the steps that we can take.
Yeah.
I think it is disproportionately more evident in psychiatry, I think, than other specialties. But I think that's the challenge of psychiatry, is that unlike most other specialties where people want your help, the vast majority of psych patients are actively working again. They like what they have. Manic patients love being manic. They love not needing sleep. They love being hypersexual. They love, the idea of running for president. Yeah, exactly. And you're the you're the party pooper coming in being like, all right, that's enough now. You need to go back to being a zombie. Of course they don't like us.
I know you're having fun, but
yeah. And schizophrenic patients are the same way. their delusions bring them a lot of comfort and safety. And we're the people coming in trying to, they don't
reality
see it.
sucks. Why are you doing that?
I was going to say, like, there's an argument to be made that, like, not all delusions are, but like I delude myself into thinking that other people know how to drive as well as I do. Coming back, to call back to what we're talking about. But like, there are delusions that become so destructive that it's, the person's now at risk. But like, part of what makes schizophrenia so difficult to treat is that what is essential is getting the schizophrenic patient to comply with their treatment and to get them to believe that you are telling them the truth and that their delusions, which they have had for so many years, whatever the case may be, is the reality. It's really difficult.
And we're strangers. We're people and they have 8 different doctors. And so it's interesting. I don't remember the exact mechanism on why, but in psychosis, like the most common first presenting symptom is paranoia, which I feel like is like the antithesis of trust. It's a lack of trust. It's an active distrust in other people. And whether it's, psychosis from schizophrenia or substances or whatever, I think a lot of people, listeners, if you like have dabbled in the edible, the devil's lettuce or things like that, one of the, aside from anxiety, like the next common like symptom is paranoia. And that's kind of like a borderline psychosis. Sorry, this is not to like scare listeners, but
the devil's lettuce. I'm not sure I've heard that one.
Whatever you want to call it, but
yeah. I have this is a little off topic, but as I was thinking about this recently, I have a prediction that the field of psychiatry is going to take a pretty big nosedive in quality over the next, I would say, 5 to 8 years. And here's the reason. There's a very specific type of person that goes into psychiatry, and historically those people go into psychiatry because they're genuinely interested in people's stories, because they approach their patients who most of the rest of society is like, put this person in a cage and throw away the key. We don't want to deal with it.
Eric Adams.
Yeah, exactly. Like we care about these people. We care about their stories, whom other people have completely rejected. However, a lot of people have caught on that psych is an awesome job where you get paid well and you have a pretty reasonable workload. So a lot of people are now going into that field for the lifestyle, not for the essence of the thing. And I think you're gonna see a real. We're gonna lose the gains we've made over the last few years. The compassion and the care that goes into psychiatry, I think, is gonna take a little bit of a hit because the profession is now being infused with people who are attracted to the lifestyle and don't realize, maybe as much as they should. Maybe I'm making a presumption that feelings are hard. And talking to patients is hard, and it's disproportionately more important in psych because of what you're talking about here. You're dealing with patients who really like the way that they feel and are actively working against your efforts to control their symptoms. So.
Well, that will be an interesting prediction to track in the future.
Not us, though.
Exactly.
We're cool.
We're in it to win it. But to continue on that, I also think this may be like a nice segue to also talk about the harm that, and it's from the patient's perspective, but also the harm that like we as a healthcare system or as an institution have done onto other people or demographics of people. I'm thinking of, I was in the CPEP, or the Comprehensive Psychiatric Emergency Program, which is a program it's essentially like dedicated psych ERs in New York City. And to see Black patients come, or not this, obviously I'm thinking of several who just like totally distrusted the healthcare system, didn't believe that we as providers had their best interest at heart, and rightfully so. I mean, we as a healthcare institution, as a government, have done harmful research, experiments. I mean, currently looking at maternal mortality rates, looking at institutionalization, looking at the research of providers who discredit pain. Like the list goes on. Totally. But I think it's like a rightful distrust, or it's an earned distrust. Yeah. We talked about you having to earn somebody's trust, especially coming from a place of harm and experience. Or there's also like experiences done directly on people. I'm thinking of, whether it's LGBTQ plus.
Substantiated. Yeah. Like it's not just a belief, but like there's actual historical proof for their lack of trust. Sorry to interrupt you.
And there's also, I think, like a direct harm that we do, and not just on like other people, on people themselves. I'm thinking of people who use substances who, get told, oh, you're just going to die anyway. You're not worth our time, whatever. Oh, just go use when you're out of here, etc.
You're a criminal. You don't deserve our empathy our compassion.
Correct. Yeah. And that similar lens, I think, can be extrapolated to people experiencing obesity, who like that just becomes like the focus of every single appointment that they go to. How is that person going to have trust that the next time they go to an appointment, or when something's seriously wrong, that their, priorities, that their wants, needs, their pain is going to be heard or listened to and not like hid behind. I mean, there's so many reasons that patients have not to trust.
And you know what? So Kate and I have been doing this project in the last year or so, where we've been interviewing patients and recording their interviews, hopefully to someday integrate them into the curriculum. And one of the themes that we've come to understand is that it really only takes one interaction to change someone's perception, positive or negative. You know, I had two examples. One from a teen mother, former, she was an older person when we were interviewing her, but she was a teen mom whose experiences made her, from the beginning distrust her, medicine. And then there was another one from a teen mom who experienced substance use and who had the same trust issues, but then had an encounter with somebody who completely turned it around and completely made her buy in to the idea that she was able to get help. And I think the message there is, you can screw it up real bad, or you can or you can turn it around to a very positive place, all, just with one interaction. But it really takes, focus and energy to understand what your influence on a patient might be.
Mm-hmm. Well, I think it's also hard because,
that was I feel like I did not express that very well at the end.
No, you're saying,
but I think you know what I'm saying.
Uncle Ben, with great power comes great responsibility.
Oh, okay.
TLDR.
We as providers have immense power. Okay, sorry, Leon. Yours.
No, well, I was just saying, because somebody who has a bad experience may not just come back at all.
Yeah.
And it's like, so.
And your goal, after all, is to keep them coming back for healthcare because they need it.
Or the other thing they can do is they could switch hospitals or doctors. So I think it's really important to keep that in mind, especially when you're interacting with the patient for the first time. Just where are they at with the medical system? Because we interact with our colleagues and patients all the time. So we kind of, I think, have a sense of what's going on behind the scenes. But a patient that has one bad interaction, they might not come back. So you may not have the opportunity to repair kind of the damage that you did. But you may have an opportunity to repair the damage that somebody else did before they came to you. So I think keeping that in mind, no pressure, but kind of seeing where patients are at with their journey through healthcare and saying, hey, this interaction that I have could be the one that turns things around, or that slowly chips away at this perception that they've built up. I mean, the same thing happened to me kind of when I first started having health problems a few years ago. I had a couple bad interactions just early on that totally turned me off of healthcare, and it was a physical problem, so physical therapy as well. And it took a really long time and a lot of interactions and a lot of trust building before I was okay, I'm ready to go back and work on these issues. But it took time, and it took a lot of reflection and a lot of positive experiences with good providers.
Mm-hmm. Tying it back to what Aline said, once you cheat once, it takes years and years. Yeah. It takes repetition to demonstrate you're working towards trust. And it wouldn't be the Short Code podcast if I didn't take 1 minute to ram against the system. And we're putting a lot of onus on providers, and yes, we have a lot of power, but also the institutions that we work in actively work against us. So I can't speak to what your experience was but I'm thinking of patients who come into primary care appointments and they have 10 minutes and they have 18 different problems that they feel are all going to get addressed. And maybe it's just expectation building on the provider's end, but the system that we're slotted in, I don't feel actively builds that arena to build trust, to I want to actively listen to, I want to get to know who you are as a person. I want to know how these problems are impacting you. I want to know what's most important to you. And to boom, that's already half the visit before they've even said their name, or introduced the first problem. And it's so hard to keep fighting against the machine, people.
Yeah. Well, on that note, that's our show. Aline, Nathan, Leon, Tyler, thanks for being on the show with me today.
Trent.
I'm not the only screw up here today.
Damn it. And what kind of untrustworthy human would I be if I didn't thank you, Shortcoats, for making us part of your week? If you're new here and you like what you heard today, follow the show wherever fine podcasts are available, like Spotify, Apple Podcasts, Google Podcasts, and YouTube. The show is made possible by a generous donation by Carver College of Medicine student government and ongoing support from the Writing and Humanities program. You may leave. I know you got things to do. Our music is by Dr. Vox and Catmosphere. I'm Dave Etler saying, don't let the bastards get you down. Talk to you in 1 week.
No latitas, best orders. Good luck at your 1 o'clock things.
Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. The Shortcoat Podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.